So welcome everyone. This is the fifth episode of season 4 of Lab Plans, where my guest joins me for a 30-minute chat on gut health, the gut microbiome, and overall health and well-being. And it is a great pleasure for me today to have my fellow nerdy girl and OBGYN, Dr. Katherine Cartwright, to talk about endometriosis and to, discuss also the overlap of symptoms between GI conditions such as IBS and endometriosis. And this is in honor of March being Endometriosis Awareness Month. So I thought it was important to have this conversation. I'll introduce my guest. So Dr. Katherine Cartwright is an obstetrician and gynecologist currently in private practice. She received her undergraduate degree in biomedical sciences and sociology from the State University of New York at Buffalo. She received her MPH at Emory University Rollins School of Public Health, where she concentrated in health education and reproductive epidemiology with a research focus in health literacy. She attended medical school at Nova Southeastern University and then returned to SUNY Buffalo for her residency training in OBGYN. After becoming board certified in general OBGYN, she attended a focused practice designation in minimally invasive gynecologic surgery. Her clinical interests include minimally invasive gynecological surgery and full spectrum obstetric care. She has a particular interest in the integration of evidence-based medicine and patient education, both individually in the exam room and on a broader community health level. Dr. Cartwright lives in Albany, New York with her husband and 3 young children. In addition to spending time with her family, she enjoys endlessly listening to podcasts and audiobooks, traveling with friends, and patiently waiting for the Buffalo Bills to win a Super Bowl. They haven't won yet, right?
They will.
They will. So we're waiting. There you go. So thank you so much for joining me today. I'm excited to have you here.
Of course.
Yeah. So should we start with the first question that I like to ask, so that we can also inspire other people, to follow degrees such as yours. What prompted you? What made you interested in following OBGYN? And also, why is this patient education, literacy, community engagement important to you?
Yeah. So I had started, science background all the way throughout my life, and really moved into the public health realm. Loved the idea of community health, of educating the public, of developing guidelines, preventive care. I really liked that community health aspect. And so I think having that background was very helpful. Ultimately, the more community health I did, the more I wanted to be sitting with individuals in the community and tailoring a lot of our public health guidelines to individuals. I found myself constantly reading, very individual case reports and wanting to understand more about how someone's personal health is really impacted by their community that they're in and how we can help them navigate that. So I really found myself gravitating towards medicine and wanting to have my own patients, my own really deep understanding of physiology and biology and anatomy and all of the things that sort of lead to our public health interventions and initiatives. Once I was in medicine, there was nothing other than reproductive health that I wanted to do. The combination with obstetrics and gynecology of seeing patients from 15 years old for, well and preventive visits, all the way up, into 80s or 90s for other medical problems that come up, seeing patients through pregnancies, through menopause, and then the surgical aspect of that, I really found myself drawn to. It was the one surgical specialty that really allowed us to follow our same patients through their life, rather than just one trip through the ER. We go to the operating room, fix the problem, and you never see someone again.
Yeah, that makes a lot of sense. I feel the same, connection. You have a relationship with your OBGYN, that's for sure.
Certainly. I think from a communication angle, when you talk about the health literacy, there is probably nothing that the general public has less understanding or health literacy actually about than their own reproductive health, how their body works, how this comes into play for all of their other aspects of their life, not just their health. And I think because of stigma, because of, you know, politics around it, there's so many aspects of this that leave people really uninformed, to no fault of their own, about how their bodies work. And so I think helping to guide people through that is really important.
Yeah, definitely. I agree. And I know how passionate you are, because we also work together at those Nerdy Girls.
Yes.
And I know that you have like a great passion for educating and advocating also, for sure.
Yeah.
So it's like we said, it's Endometriosis Awareness Month, and endometriosis is one condition that is, you know, difficult and deserves, you know, to be talked about. So what is endometriosis, and what are the symptoms that are associated with this?
Yeah. So endometriosis is it's a benign condition, meaning it is not a cancerous condition. But in a lot of ways, it sort of acts that way, where it can spread into a variety of areas within the body. So endometriosis is when we see cells that resemble the cells of the lining of the uterus. So these are the gland cells that build up your lining that sheds when you get your period each month. There are cells that resemble those cells and have moved into other areas of the body. There's a variety of ways that they can do that. There's lots of different hypotheses, and probably all of them are right in different people. But when those cells move to other areas of the body, they have the same hormone receptors that your lining of your uterus does. So when you go through your menstrual cycle and those cells sort of swell and get ready to build up and then to bleed and to be activated, these are hormonally active cells. So each cycle someone has, they have cells that are not where they belong, that are swelling and can cause a lot of inflammation in those areas. We most commonly see this on the ovaries, surrounding the uterus, and in the pelvis, but we can see it outside of the pelvis as well. We can see it on the bowel. We can see it in the upper abdomen. There are reports of endometriosis really distantly, like in the lungs. That's pretty rare and is not what we see most often, but it really can be anywhere. And because it's hormonally active with every cycle that someone has, there's activation of these cells.
Mm-hmm. And therefore, the symptoms that people feel are similar to inflammation and pain and all that. Can you elaborate a bit on the
Exactly.
symptoms?
Yeah. So typically the kind of inflammation you get with a period is within the uterus. And so the uterus cramps and you have a period, and that's sort of that. Now, some people have very, very painful periods and don't have endometriosis, but when you have other areas of your body that are not supposed to be getting cyclically inflamed every month, and it is happening, there is inflammation then in areas that should never be inflamed. And so we see this commonly between like the ovary and the sidewall of the uterus, or between the vagina and the rectum. We can see this around the bladder. We can see it with bowel, where bowel is sort of stuck in areas. And so each month that these cells are activated, that inflammation causes a lot of tethering, a lot of pulling, can cause structures to be stuck together that are not supposed to be stuck together. There's a lot of nerve involvement in these areas. And so I have a pelvis that I often will show patients that shows the muscles that sit within the pelvic floor. They sit like a hammock almost, and it's lots of different hammocks that are sitting within the pelvis. And all of your organs sit on these areas. And so when you have inflammation of those organs, the muscles themselves become really inflamed. They spasm. There's a huge amount of muscle dysfunction that goes along with this. So really primarily inflammation that leads to significant pain in many patients is how we see endometriosis present.
Yeah, that's a lot. And is that how common is that in your experience and in the data, of course, the literature?
So most data shows about a 1 in 10. So 1 in 10 women will have endometriosis based on the data that we have. There certainly is a lot of endometriosis that goes undiagnosed. One of the very difficult things is that the severity of the endometriosis clinically, when we look, is not always directly analogous, directly the same as the amount of pain a patient may have. And so I, in my practice, often see patients who I'm operating for something else, fibroids, something unrelated to endometriosis, and I find really significant endometriosis, and those patients have absolutely no pain. And then I find patients with severe pain who clinically have smaller areas of endometriosis, but their pain pathways or the specific spots that those are in can lead to much more severe pain. So this makes it very difficult to diagnose. 1 in 10 is probably an underestimate of how much endometriosis is actually there.
Yeah, makes a lot of sense. And how is it typically diagnosed? So by
So
accident?
by
Of course.
accident. So the sort of classic historical gold standard for diagnosis of endometriosis is surgical. It is to look inside someone's abdomen, pelvis, wherever you suspect the endometriosis, to take a biopsy of the tissue that looks like endometriosis, and to have a lab look at it under a microscope. There are increasingly effective imaging modalities now, MRI, even just ultrasound, that can give us a very high clinical suspicion of endometriosis. And most endometriosis doesn't need surgery to diagnose it. I will often have a 95+% clinical suspicion of endometriosis, and to immediately jump to surgery in those patients just to prove our clinical thought isn't always what we do. I think that also contributes to some of the delays we see in diagnosis.
Yeah. I was gonna say that if you read about endometriosis and the literature, that you have a long delay that can be up to even 10 years, which kind of also coincides with the delays we see in IBS diagnosis as well, like these conditions where you have the pain but not a distinct physiological change that you can see right away. So so the diagnosis, I guess, what makes it so difficult, I guess, besides the fact that it might not be visible?
So I think this is multifactorial. The one thing that I like to point out often is, because we don't land on a definitive diagnosis without surgery, I do think there are situations where an individual may feel that they don't have an endometriosis diagnosis for this, 7 to 10 years that gets quoted. But it's very possible along the way, the clinicians that have seen them are thinking, oh, this is probably endometriosis. Let's treat it with some of our kind of standard treatments. And maybe a lack of communication of that, a lack of having that definitive pathologic diagnosis. I will often have people, it's often a long time from when symptoms start to when you actually end up with an operative diagnosis of endometriosis. And there's a lot of suspicion of disease along the way. So I think that kind of confounds the 7 to 10 year information. I don't think people have no idea this is happening. It's just not proven until you have pathology. I also think it presents in very different ways in patients. There are people who don't end up with a gynecologist for years and years and years because their symptoms are GI related, or their symptoms seem to be related to other systems. And so the interplay, I always say it's kind of like the Scarecrow and the Wizard of Oz. The GI system and the GYN system do this to each other because they're sitting so close, and inflammation in one leads to inflammation in the other, and sometimes it takes a long time to sort that out.
Right. Yeah. Oh, good. So that basically leads me to my question about GI. So do you generally see a trend, like if someone has endometriosis, are they more prone to have IBS? There is this huge overlap of symptoms, like we said. So what is the connection there?
Yeah, there is a significant overlap in these symptoms. And whether these are really distinct entities, whether IBS is a distinct entity in patients with severe endometriosis, or it's just a manifestation of their endometriosis, is often really debated. There can be GI symptoms, constipation, diarrhea, all of the things you see with GI symptoms are also present with endometriosis. And a lot of this has to do with that interplay. A lot of the hormones that trigger the endometrium and the uterus itself are also present on the bowel. So things that make more uterine cramping happen can increase motility of the bowel and have things start moving much more quickly. And then that happens on the opposite side as well. You can even have endometriosis, and this is not uncommon in more significant endometriosis. Bowel involvement, where there's endometriosis that has grown into the wall of the bowel, is common. So in those cases, there may be patients who only have endometriosis that is on the bowel, so all of their symptoms are bowel related, and they don't end up, with a GYN diagnosis. This is all sharing the same space. And so if an environment is inflamed, or if cells are spreading in an area, these organs are all touching.
Right. Yeah. And that makes a lot of sense. And generally your first thought will be you as a patient, I mean, that is GI, that is something GI, right? If you're constantly getting diarrhea or constipation, if you have this abdominal pain that even for me, like as an IBS patient, like every cycle, obviously your symptoms are different, right? At different times of cycle. So you always think it's because of my IBS. So there is the chicken and the egg kind of situation as well in this. But it's good to know that there is all this overlap with GI, and for people to kind of question their symptoms, right? So we thought it was important to kind of touch upon this, since endometriosis impacts people's lives so much. What would be some tips or some good ways that people could talk about their symptoms to their clinicians, how they impact their daily lives, so that they can help the clinician, reach the diagnosis. And then also, since, you're a clinician, if you can also say how maybe clinicians can facilitate this, how they can encourage patients to open up more about this, because these are touchy subjects, obviously.
I think this is the bulk of where we are overwhelmingly failing people. I think that figuring out the symptoms someone is having, what is causing them, and then what that individual person needs is really often the challenge here. So I often will tell people, when you go to see someone about a problem that you're having, or you go for a general wellness visit and they're asking questions, having an idea of not only what symptoms you're having, but how distressing they are to you and what you want done about them, I think is very important. Sometimes I will talk to someone and they're telling me, yes, my periods are terrible, they're really heavy, this is happening, and they're just reporting that information. And I'll start talking about potential options for treatment and workup, and they say, oh no, it's fine, it doesn't bother me too much, it's okay. Well, that's someone that maybe doesn't need anything else. Knowing that there's treatments available and what they are is important, but that's not someone seeking answers. Sometimes I think someone goes in seeking answers and they're perceived as that first individual who's just kind of reporting symptoms. So I think really describing how distressing this is affecting my life in XYZ way. I cannot continue in this way, and these are all the things I've tried, and I'm really hoping you can help me find a way to deal with these particular symptoms that are really bothering me, or what are your concerns? Often saying to someone, what do you think this is? What do you think is going on? Reveals a whole bunch of information, because they've been reading and looking into some of their symptoms on their own, and sometimes addressing the concerns from a clinician side of what someone is most concerned about can help either rule that thing out or can lead you down a way where you can help them explore that a little bit more.
Yeah. So just be open with how you feel, and also kind of also acknowledge, I think, how much it impacts your quality of life, so that then you'll be heard and you'll
Right. And I think with endometriosis specifically, this presents so differently in different people. And, from a treatment standpoint, there's a wide variety of treatment, which I think is probably really outside the scope of a quick talk today. But I typically kind of put these into 3 categories. So we have things that address some of the downstream effects of endometriosis. So pelvic floor physical therapy is a hugely important component of treatment of endometriosis. Some pain control, some mental health counseling. Living in pain for a long time has huge mental health impacts for people. Those are sort of your non-gynecologic but downstream effects of endometriosis that really are one part of treatment. Then you have options to actively treat endometriosis, and there are medical options, which really almost always are hormonal management in some way. If these lesions are hormonally active, manipulating those hormones and decreasing how active they become, and so either suppressing cycles or using some other hormones in different ways to try to medically manage is one thing. And then surgery is a whole nother treatment modality.
Right.
So knowing what things you're looking for and then getting into the hands of the people that can do those things is really important. I think having really starting with either a general physician or a gynecologist that can help guide you is important. I do what I do, but I don't do pelvic floor physical therapy. I don't do mental health counseling. I do a lot of surgery, but there are components of endometriosis surgery that I don't do, that I refer out for. I don't do bowel work. I don't do liver and diaphragmatic endometriosis. There are things that I don't do, but you want someone that has built a network. I know who to send these people to. I know when to say, I adore you as a person. I am not the person for this. And I want to get you into the hands of the person who can best help you. And I think it's important when finding someone to find someone who is very willing to say that and to help direct away from them if that's the best option for you.
Yeah, I think that's very, very important. And also if it comes from a clinician that you trust and that you have built a relationship with, then it makes it easier to then transition to the other person who has the certain expertise to treat you for something else or to help you with something else. Mm-hmm. And it's interesting how you said, the mental health aspect and the pelvic floor exercises. And again, all this is also what would be recommended for someone with IBS or with GI conditions, because we know that everything is intertwined and interconnected, mm-hmm. and the gut-brain axis. And if your gut is affected, then you can also help target it in different ways. So it's good for people to know that they have options, I think, because in our minds, when we think endometriosis, we just always think surgery. I think. Mm-hmm. So it's good to know that. And like you said, it's a huge question to tackle, like what treatments are there, but mm-hmm. it's good to know that there are a lot of different options for people. That I know there is no cure, right? Mm-hmm. But the treatments do significantly improve quality of life, right? Based on, your experience and data that is out there.
They do. And really sort of the mainstay, and this doesn't mean everyone jumps to this right away, avoiding surgery as long as possible is often beneficial, but then avoiding it too long can also start to harm as well, because there can be some more irreversible changes that happen the more time goes on. So the sort of mainstay for someone with significant endometriosis, if they continue to have symptoms that are not well managed with some of the medication options or the medical options that we have. When we talk about surgery, we talk about excising or removing areas of endometriosis and trying to restore normal anatomy. So if things are all tethered and stuck, we want to unstick them. We want to remove the lesions of endometriosis. The goal of endometriosis surgery is to get all of it, to get all of the visible endometriosis. Even though this is benign, it's not a cancer, it acts like that. So there can be a microscopic disease that then will grow after you've had surgery. We removed it all today, but years from now, if you do nothing, that will come back over time in almost everyone. So really suppressing medically after surgery, pelvic floor physical therapy, other pain management modalities are really kind of this big multidisciplinary, get everybody involved, best practices, best way to treat endo with really long-term results, because ultimately not living in pain and the fertility aspect of not negatively having your fertility impacted, hopefully, are really the goals. And so how do we get to that? It's going to be individualized in everybody.
Yeah, yeah. Which is basically the way medicine is approached, or I guess the
Right.
future of medicine, right? Yeah. Do we
Mm-hmm.
do we know what the root cause is, like how it starts? Do we have
So
evidence?
there is evidence of a couple different ways that endometriosis can spread. One, and sort of the oldest school of thought, has been what we call retrograde menstruation. So if you have your uterus, I wish I had one of my models here, I don't. If you have your uterus and you have your tubes come out, when you get a period, some blood goes back through the tubes and spills into your pelvis. Most of it comes out, but some of it spills out. And some people are more prone to have more spill out than others. So there's some endometrial cells in that backflow of blood through your tubes, spills into your pelvis, your body reabsorbs it and goes away, but they may implant. That's probably where a lot of ovarian endometriosis is coming from, and pelvic endometriosis, because it's directly spreading onto what it lands on, which is the rest of the pelvis. We also know there must be other mechanisms, because we find distant endometriosis. It's been found on the diaphragm, often on the diaphragm, in the lungs, in different cavities of the body. And so there must be some hematologic or spread through the blood, endometrial cells that actually spread to distant areas in the bloodstream. And there's probably a combination of these things that happen in patients of how it is spread. But there's good evidence for at least those two modalities, as well as a couple other more rarely seen ones.
Yeah. Wow. Wow. That's amazing to think that. And it doesn't mean that if you find endometriosis in the organs around the reproductive organs, it doesn't mean that everyone is going to have also distal, like, endometriosis
Correct.
right?
Correct.
So it could be either or.
Yep.
Yeah. So that
Yep.
also makes it more complicated to figure out the mechanism,
Mm-hmm.
because why for some you have this distal movement and for some others not.
Right.
Yeah.
Yep.
It's a fascinating field. Well, that is all really, really, really helpful and very, very important. So I think we touched upon everything that I had in mind. I don't know if you have any last thoughts before we move to my last question, which is not relevant to endometriosis.
Yeah. I don't think that I do. I think for patients who or people that are out and seeking care, I think if this is something you are concerned about, use those words. Tell your gynecologist, I'm concerned about endometriosis. Is this something you feel like you are comfortable managing? And do you have suggestions of someone else that maybe I should see to have this further evaluated? I think specifically asking that, if you have these concerns, is probably the best advice that I have to get things started and get things moving for yourself.
Yeah. I think that's really important coming from a clinician to say, because this is kind of what I did with my IBS. Like, I walked into a gastroenterologist's office in the US when I was a student. I said, I think I have IBS. And I was a little hesitant, because you feel like you don't want to tell your clinician, like, self-diagnose. But I guess you know your body. And
Right.
if it's one of these conditions that you've had symptoms for a long time,
Right.
it's okay to speak
Yeah.
up, right?
And I think it is helpful for us to know, because there are times the patient comes in and says, I think I have X disease. And sometimes they say, oh, this is why you were so concerned. We see this with cancer a lot. I think I have this type of cancer. I think I have this thing. And sometimes we can actually, even if it's not endo and you go in and use that approach, if you have someone who communicates well with you, we can say, I totally understand why you think that. Here are the very specific objective reasons I don't think that's going on, right? And sometimes that's all they need, is to say, oh, okay, so we can cross that off the list.
Right, exactly. And we can relax and then have the conversation to figure out why.
Right.
Perfect. Well, thank you for all this information. Before we go, I wanted to ask you the question that I ask everybody who comes here. The Instagram live is called Love Plants. So I was wondering, do you have a plant-based favorite? It can be a recipe, an ingredient, something that you love at home with your family that you would like to share with us?
So I have 3 kids who from day to day have a favorite food that becomes their least favorite food. And so trying to find things that they'll eat is a challenge. My, I guess, plant-based hack is I add lemon to everything I possibly make them, and they find so much joy in taking half of a lemon and squeezing it on that they will eat almost anything. If I put some lemon in it, pasta, veggie, pasta, whatever it is that I make, if they have control over that like sour sweet, they're all about it. I can make them eat almost anything with that.
That's a great trick. And all three of them actually like that?
Yeah. Yes.
Yeah. My little one also loves to, lick the lemon and the hands, of course, and the beautiful smell. Well, as a Cypriot, because, in the Mediterranean, lemons are, a big thing. I love that hack. So I hope people try it at home. Thank you for sharing. Thanks
Problem.
again for coming on here and for all this information that you shared with us.
Sure, no problem at all. Thanks a lot.
Take care, Kath.
Take care.
Bye.